Hi, my name is Dana and I'm the nurse educator at El Paso Emergency Room. Today we're going to be going over everybody's favorite skill ever, chest tubes. Chest tubes are one of those things that if you don't work with them too often, they're very intimidating and confusing, so it's good to know what's normal and what's not. So let's get into it. I will go over the different components of the Pleurovac, how to set up for insertion, how to do a dressing post-insertion, and some troubleshooting tips along the way. So there are two types of chest tubes. You got your dry suction and the wet suction. In the end, they both do the same thing. They're both connected to the wall suction. They just work a little differently in the way that they create that negative airspace. So the dry suction uses like a little dial or like a regulator to manually control the suction pressure. So no matter how much wall suction it's at, that's what's going to control, not the wall suction. And the wet suction chest tube, which is this one, uses water in the chamber to regulate that negative pressure. And that's very important because this is the only one we carry here. So you have three chambers. You have the collection chamber, the water seal chamber, and the suction control chamber. So the collection chamber, pretty self-explanatory. It collects fluid or blood and it's measured in milliliters. The water seal chamber, this acts like a one-way valve. It allows evacuation of air from the patient's chest cavity, but it's preventing its re-entry. So it measures the negative pressure in the patient's pleural space. There's this little ball here that kind of titles up and down, and it should correlate with your patient's inspiration and expiration. Now, you may notice some bubbling here. This can be a normal thing, but it can also not be a normal thing. Bubbling means that there's an air leak, like with a pneumothorax. So when you have a pneumo, it's expected to have some bubbling in that chamber initially because there's a large air leak. So when the lung has fully expanded or the pneumo has resolved, then the bubbling stops. Or bubbling can also stop if you have a kink. If you see continuous bubbling and it's not expected, this typically means you have an air leak somewhere in your system. So check out your connections, make sure there's no leaks, punctures, or anything in the tubing, and make sure that you're connected to the actual chest tube of the patient. Then you have your suction control chamber, which is right over here. How much water you have in that chamber will control how much suction is being used. That's why this is called a wet suction chest tube. The typical prescribed amount is 20, but follow your MD orders and how much suction they want. Bubbling is okay over here. Bubbling indicates that the suction is working. If it's not bubbling, then the suction is not on or not working and you need to troubleshoot that. I'm going to show you in 4 easy steps how to set it up. So first, fill the water seal chamber. You're going to grab the funnel that is found on top of the Pleurovac unit and connect it to this short end tubing. Now I know it doesn't make sense to connect it to the suction port, but this is where it goes. Next, make a kink or bring the funnel down. Grab an irrigation bottle or about 60 milliliters of water and fill it up to the fill line. Which ends right there. Next, bring your funnel up so it can fill your water chamber. Notice how it turns a blue color. It should be at the 2 centimeter level. Step 2, we're going to fill the suction control chamber. So we're going to open the yellow rubber stopper and we're going to be adding water through this vent to fill it up to whatever desired level the doctor has ordered. And it's usually going to be at the 20 line. You're going to close the rubber stopper back up, connect the short tube to the continuous wall suction, and you're going to turn it on until gentle bubbling occurs. The bubbling will cause evaporation over time, therefore decreasing the level of suction. So if you want more suction, then add more water. And you can add more water either through the vent on the top or through the yellow self-sealing diaphragm using an 18 gauge needle. Step 3, connect. So after the doctor has inserted the thoracic catheter on your patient, grab the collection chamber tubing. Just make sure that you keep the end of this sterile. So don't touch this when you're going to hand it to the doctor. Step 4, stand it up. So you're going to grab the kickstand on the bottom and turn it over to make a T. Go ahead and secure it on the floor, or you can also put it on the lowest part of the stretcher. Just make sure that we are not raising it above the chest level. So after the physician has inserted the chest tube, let's put a sterile dressing over it. Step 1, gather all your supplies. Step 2, clean off any excess blood or fluid from the insertion site and allow it to dry. Open all of your packaging onto your sterile field, then apply your sterile gloves. Step 3, apply an occlusive dressing. We got the 0 form over here around the chest tube at the insertion site, making an airtight seal. And we have intact packaging for demonstration only. Step 4, apply some split 4x4 gauzes around the chest tube so that the openings don't lie directly over one another. And then you can add either some additional 4x4 gauze dressings covering the chest tube or an ABD pad if more absorption is anticipated. And step 5, apply some silk tape to create an occlusive dressing. It will take several pieces, so cut those ahead of time. So now for some troubleshooting tips or some gentle reminders. First, you never want to be milking or stripping your chest tube because this can increase your negative pressure. Second, you never want to be clamping the chest tube. The only reason you may clamp the tube in case of an emergency is if the system breaks or gets accidentally tipped over and now you need to exchange the whole Pleurovac system for a new one. So you would clamp it, exchange the drain system as soon as possible, and then unclamp. And your last reminder, so if the chest tube gets pulled or dislodged accidentally, because it can happen, well, first get the doctor. In the meantime, get some sterile 4x4 gauze and place it over the site, but only tape it to 3 sides. So this 3-sided tape allows for air to escape when the patient exhales. And when they take an inhale, that side should come down, occluding off the site, so no air can get into the pleural space.